of all, thank you very much, Marty and Spa, for inviting me to present one of the great topic around the survival of newborn and young infant and improvement over the time, the management of bacterial infection in newborn and young infants. My name is Yasir Bin Nisar. I'm working for WHO headquarters in Geneva for the Department of Maternal, Newborn, Child and Adolescent Health and Aging. Today, I'm going to present one of the topic which is very close to my heart also, that how we can improve the management of young infant with possible serious bacterial infection. And this is a very unique topic because in the last 15 to 20 years, uh, this helps us to, from research to change the policy and finally the practice in just 15 years time period. So it is one of the great success story from WHO, and that how things move when global partners and local investigators involved in these sort of topics. So welcome everyone and good afternoon. Yeah. So just to remind ourselves what are the global causes of neonatal mortality, and we all know that 47% of under five deaths are due to neonatal deaths. That is first 28 days of life, which is the most vulnerable period. And the three leading causes are prematurity, birth asphyxia, and neonatal infections. If we see global picture, the neonatal infections contribute about 22% of neonatal mortality, almost one fourth. But unfortunately, in South Asia and Sub-Saharan Africa, the contribution is little more than 35% due to neonatal infection for the neonatal mortality. So that is why this topic is very important for these two regions of the world where we know that most of the mortality in newborn is occurring. So what are the strategies to prevent new mortality related to infections? So WHO introduced intervention based on three thematic areas. So the two are promote and prevent. That means we need to adapt uh, health promotion intervention and preventive measures to prevent infections in newborns, such as we all know that preterm or low birth weight babies are prone to infection, so they need extra care to prevent them infection. Similarly, some of the basic hygiene practices can prevent infection, not only in the hospital, but also outside hospital at home as well. Exclusive breastfeeding and skin to skin care or mother skin to skin contact or mother kangaroo mother care is very important in preventing infections, and we have seen that in many research settings it have shown that the value of KMC is quite high. Cord care and then some of the maternal immunization also help in preventing the infection in newborns. However, if there is an infection, then what would be the optimal treatment for those newborn and young infants? So first of all is the use of appropriate antibiotics. It's very important that we should use the appropriate antibiotic with the appropriate dose and the duration also. And whenever there is a need for oxygen or any other supportive care in the hospital, it should be provided immediately. Lastly, care of preterm is very important, and we know that antenatal corticosteroids and respiratory support are important in terms of treatment also. So, in when we call newborn infection, it's a very wide and diverse area, and WHO define it as call it as a possible serious bacterial infection for public health settings. So commonly we call it as a PSBI, but we know that it's a combination of many infection, including meningitis and some viral infections. But you know it's very difficult to distinguish between viral and bacterial infection, and there is no such point of care diagnostic test with a high sensitivity and a high specificity to let us know which is viral and which is bacterial infection. That's why whenever there is an infection, even we empirically start the antibiotic because of the bacterial infections. So how we diagnose PSPI? Very simply using the clinical signs only, so that we can identify these children earlier, uh, and do the appropriate management according to their condition. So what are these signs? These are not able to feed at all or not feeding well, convulsions, a very severe sign, severe chest syndrome, then two signs related to temperature, high body temperature, fever, or low body temperature, hypothermia. Then two signs related to movement, because it's very important to see the movement of the child also. So movement only when stimulated, or not movement at all, like lethargic. And then the one sign related to respiratory rate, which we call fast breathing, and the cutoff is 60 or more breaths per minute in infant less than 7 days old. Uh, the one study which was conducted multi-center studies in early 2000, during the decade of 2000 and 2006, in many countries, they actually evaluated the sensitivity and specificity of these signs and came to know that the sensitivity is 85% and 75, and specificity was 75%. That is why they use these signs. uh, Sorry. And when we estimated that it is about 7 million cases of PSPI globally, and again, the higher proportion is in South Asia and Sub-Saharan Africa. So this is a conceptual framework how we can manage PSPI cases. So the first and the most important thing is that we should identify these signs as early as possible. And once you identified these signs in the community by community health workers or by mothers or any family member, they should be referred to a health facility for further management. And about the health facility, our trained health workers should reevaluate the child and confirm these signs of infection. The next year after confirmation, all these young infants, we call young infant because the infection is quite similar in the first 60 days of life. The organism is also quite similar when they are in the community. So we this management is not only in the newborn period, but beyond newborn period in the first 60 days of life. So once they confirm the sign, ideally all of these infants should be sent to the hospital, and they should get the appropriate treatment in the hospital. So for all these places and care, we WHO have guidance and guidelines for healthcare workers and for physicians also. So right from the beginning in the community, we have a community health workers guidance that how they conduct the postnatal visits and identify danger signs which is related to infection. Then these kids should be referred to a health facility where we have IMCI module, where they have module for less than 2 months of age, where they reassess the newborn and young infant for any signs of PSPI. And lastly, we have a pocket book for the hospital management of these young infants. So with this, the first edition of IMCI, Integrated Management of Childhood Illnesses in 1997, they identified 13 signs of infection. And any one of these signs, at that time, it was considered as a danger sign, and the newborn and young infant should be referred immediately to the hospital without any delay. However, with the same management concept, that identification till treatment, we have seen that there is some issues. And one of the major issue was low compliance with the hospital referral. There are a number of researches after 1997, I think starting from 1995 till 2008, from India and other countries, where they identify that only 20 to 30% of the PSPI cases actually accept referral and they reach hospital. So majority of them, 70 to 75% of the cases, they refuse referral, and then they are actually getting some sort of treatment which is inappropriate at that time. So that was the major reason that even with the IMCI, we were unable to get the high coverage of PSPI treatment. So then the question was how we can improve the PSPI treatment. We know that these young infants are having danger signs, they need treatment, but once they refuse hospitalization, there is no alternate management for them. So in that aspect, there were two complementary strategies. Number one, to facilitate referral and improve quality of care in the hospital, so that those who need hospital, they can reach immediately to the hospital, and even in the hospital they can get the high quality of care with the appropriate antibiotic and other supportive care, including investigations. The second strategy was, even if there is not possible for referral due to any reason, due to household reason or due to community reason or even due to some sort of hospital reasons, there is another possibility of giving the treatment closer to home, that is outpatient treatment for these infants. Therefore, the the first strategy was taking a much more larger time, as you imagine. And if I ask you this question, you know that how difficult is in many of the low and middle income countries with resource poor communities to refer a young infant from community to the hospital. There is no roads, no transport, no public transportation. On the other hand, the second choice, there was this was discussed in 2009 in a meeting in WHO, and many global players as well as local investigators participated in that meeting. After that meeting, it was considered that we should evaluate this second strategy through randomized controlled trials. In this context, WHO coordinated research in Africa and South Asia between 2010 and 15 to see the safe and effective treatment when referral is not feasible. These studies were conducted in Nigeria, in Africa, in Nigeria, Kenya, and Congo, DRC, and in Asia, these were conducted in Bangladesh and Pakistan. The results were very interesting of these studies. We tested 5 different arms of treatment by giving injection and oral in one of the arm. And based on these findings, we actually launched the first ever guidelines for the management of PSPI when referral is not feasible in 2016. The key components of these guidelines first was identification of signs of infection in the community at home. So we provided the clear strategy for community health workers that whenever they visit postnatally to assess the child or a newborn, they should identify these danger signs. Second important strategy was again the similar to the previous one, that once they identify these signs of infection, they should the young infant should be referred immediately to the primary healthcare facility. However, we changed one important thing from the last IMCI. That is, the 7 to 59 days old with only with one sign, fast breathing, they don't need hospitalization actually. They can be treated with oral amoxicillin twice daily for 7 days without referring to the hospital. So at least if you ask me, at least in PSBI, there are 15 to 20% of the cases where only the fast breathing sign was present, no other sign was present. So we actually exclude 20% of the young infant who actually don't need hospitalization for their treatment. Second is, the important thing is to facilitate referral. We know that those children with signs of PSPI, they need hospitalization. So let's facilitate the referral. But if referral is not feasible, we actually provided a recommendation that these children, our young infant, can be treated with 2 days of gentamicin once daily and plus 7 days of oral amoxicillin while staying at home and visiting the facility only to get gentamicin on day 1 and 2, and then continue with oral amoxicillin. But in addition to that, the mothers and the family members were also learned about danger signs, appearance of any danger sign or reappearance of any danger sign, and a mandatory day 4 visit to the facility to reassess the newborn if there is any other danger sign or reappearance of any other danger sign is there and the child needs hospitalization at that time. So with that, we actually revised the IMCI child booklet in 2014 and later on in 2019. In the difference between the two is that the fast breathing in 2014 was included for first 2 months of life as one of the danger signs, while in 2019 it is only first week of life as a danger sign. From 7 to 59 days old young infant with only one sign, fast breathing, they can be treated with oral amoxicillin in the community. So we did not stop here by launching the guidelines. The next step was to see whether these guidelines are good enough to be implemented in program settings, because these guidelines were built based on clinical trials, and we all know that in clinical trials we have some sort of artificial ground, artificial sort of things. So we would like, and there is some concerns also from program managers that once we implemented the program setting, we will see a larger number of consequences with this treatment, even not only with the severe with the side effect, but also the poor clinical outcomes also. So in this context, we actually conducted and coordinated implementation research to implement these possible serious bacterial infection guideline when referral is not feasible between 2016 and 2019 in 6 sites in Africa and 5 sites in Asia. The aim was very simple. It was to learn how to implement PSPI management guideline in a study area and use the lesson learned for scale up, not only in that particular country, but also many other countries where these guidelines are important. We have published this all the results from these implementation research in +1 supplement, which is known as neonatal infection collection. For 5 key areas of implementation research, which I put it here, and these are very important whenever we decide to do the implementation research. First is orientation and policy dialogue with the stakeholder, especially with Ministry of Health and other stakeholders, including neonatal and pediatric associations. They are very important and very supportive in implementing this sort of strategy in many of these countries. Secondly, establishment of technical support unit, because they need support from experts. It's not easy to implement this sort of guidelines in programs. Thirdly, creation of learning platform at the implementation sites, which can help them not only to rectify some of the things right there, but also the lesson learned from there to use for the scaling up of this strategy at the subnational or national level. Strengthening the health system is very important, including the HR capacity by providing training, supplies in terms of equipment and medicine. Postnatal visits by community health workers are essential to identify these cases as early as possible. Community sensitization is also very important, because when community knows that they can get the treatment closer to their home, they prefer to visit those facilities rather than going to the hospital with all those difficulties facing during their travel. And then obviously monitoring and problem solving are integral part of this research project. Lastly, continuous use of data is very important, and we try to emphasize policymakers, program managers to use the data for their policy making exercise also. We actually put 3 key qualitative outcome for this implementation research. One is referral acceptance rate. there was some concern that once we offer outpatient treatment, people would not accept referral and they prefer to have outpatient treatment. So we put it as a one of the key qualitative outcome for this implementation research. Second was that coverage of inpatient and outpatient treatment, because there was a concern that even with this coverage won't increase. And lastly, most importantly, about treatment failure and mortality when we provide the outpatient treatment in a program setting rather than in a research settings. So the first question was referral acceptance rate. We have seen that overall it was 19% acceptance rate. So no major dramatic reduction in the acceptance rate. Previously, we have seen 20 to 30%. So when offering outpatient treatment, it was 19%. But you can see a lot of variation among those sites. Some of the sites like in Nigeria and in India, which are very poor and the transportation is really difficult to reach the hospital, their referral acceptance rate was very low, less than 5%. On the other hand, in Pune, in Maharashtra, in India, where we have a very good roads and free of cost ambulance services, their referral acceptance rate was very high. It was like 90% of the newborn and young infant who were identified as case of PSBI, their family accepted referral. So the second question which we asked during this implementation research about the coverage of inpatient and outpatient treatment. So overall, we were achieved 76% of treatment coverage based on number of PSBI cases. We usually take incidence rate as a 10% of having these signs of infection among all live newborns. So based on that, 76% actually received the treatment. And you can see that it was mostly because of outpatient treatment. That's why we have a higher proportion of coverage for the management or for the treatment of PSPI cases. And lastly, about the poor clinical outcome, and we can see that the overall treatment failure when giving the outpatient treatment was 3%, but the mortality was still on a lower side, only 1.3% in some of the selected areas. So what key lesson we learned from this implementation research? Number one, health system challenges. When we want even to scale it up, we know that there are some challenges at the health system level and some challenges at the care seeking level also. So we need to resolve these challenges. First and most important is availability and competence of human resource. Very important, because we are offering treatment at a lower facilities. So the staff should be trained and they should know their clinical skill to identify these young infant with the signs of infection immediately. Second important thing which we faced is inadequate coverage of postnatal home visit by community health workers. This is a very good strategy that community health workers should visit young infants after birth, day 3, day 7, day 14, and day 21, and then day 42, at least 4 to 5, 6 visits to identify any danger sign or any problem with the newborn during that period. But unfortunately, in many of the countries, we have seen that still the coverage of postnatal home care visits are on a lower side. Third is stock out of essential supplies, including the thermometers, including the ARI timers, including the medicine, was one of the key challenge which we faced during the implementation of these guidelines. Fourth important is closure of facilities. We know that hospitals seldom close. They are always open 24/7. But these facilities, lower facilities, they usually close on public holidays and the weekend. So that was another problem which we faced during the implementation of this guideline. And lastly, HMS and DHIS not developed to track PSPI cases. And we actually introduced a parallel system for this research, but now we are try to incorporate PSBI within the context of health management system and district health management system, so that policymaker and program managers should use this data for their policy making exercises. There are some care seeking challenges also, such as delayed in identification, incorrect decision about healthcare provider, and financial and logistic barriers in care seeking. So how can we achieve? So secondly, because we achieved about 76% of the coverage of treatment, so the question we asked to ourselves that how was high coverage achieved in this implementation research? And this is helpful for all those countries who would like to scale it up, this strategy at subnational or national level. First and foremost important is engagement of national technical expert and policy dialogue with MOH. When I say technical experts, it's mostly neonatal, and it's a professional association such as neonatology and pediatric association in those countries. Then we actually incorporated PSPI management not as a standalone part, but into IMNCI so that health workers can be trained in that, and then they have enough confidence to treat these young infant in their facility. Then community health workers visits are very important. In some of the areas, they identify the children well in time and refer them to a facility for appropriate treatment. Required antibiotics and other equipment is very important, and then we should measure the treatment coverage on a regular basis to make any decision on further scaling up. We did not stop actually here. We actually, when we say this is a new area which I want to introduce you, that we call any one sign of infection as PSPI, and the management is of same, that this child should be referred to a hospital and should get inpatient treatment for 7 to 10 days of antibiotics. And if referral is not feasible, we can offer them an outpatient treatment with 2 days of gentamicin and 7 days of oral amoxicillin in the outpatient treatment strategy. However, if we see closely, these signs, these 7 signs, their prevalence as well as their mortality rate are different. So we did a secondary analysis of previously collected clinical trial data and came to know that the most prevalent signs, such as high body temperature, fever, severe chest syndrome, and fast breathing in 7 to 10 days, 7 to 6 days old, their prevalence is quite high overall. It's about more than 50%, but among all the PSPI cases, but the mortality is quite low. It's only 1%, 1.2% when they receive the appropriate treatment. When I say appropriate treatment, it's either in the hospital or as an outpatient management. However, few signs, and we call these signs now as a low mortality risk signs. However, few signs such as movement only when stimulated, not feeding well, hypothermia, or multiple signs, they have a relatively high mortality with low prevalence. Their mortality range from 3% to 11%, and on average, it's 4% overall. However, some signs which we call critical illness signs, they have quite a high mortality. Where even with the treatment, they are having 7%, 17% of mortality. These signs are such as signs of convulsions, not feeding at all, or no movement at all. So, based on these further or secondary analysis criteria, we proposed and we are now conducting two large randomized controlled trials in Africa and Asia, which we call Trial 1, PSPI Trial 1, where we consider the single low mortality risk sign, any one of the signs which I mentioned in the previous slide, such as fever, severe chest syndrome, or fast breathing in first 6 days of life. We are actually randomizing them into two groups. One group is as per the standard management of WHO, inpatient treatment for 7 days of ampicillin and gentamicin in the hospital and other supportive care. And the other group is actually getting the outpatient treatment with 2 days of gentamicin and 7 days of oral amoxicillin. We started this study, this clinical trial in June 2021, and we are going to complete it by June 2024. The 7,000 sample size is going to complete it by June 2024. 2024. And then we will publish this. And hopefully it will help us to review the current policy, either to revise it or to strengthen the current policy of management of possible serious bacterial infection. The second trial, we have seen that even in the secondary analysis, that the first 48 hours is crucial for young infant when they are admitted in the hospital. And most of the mortality is happening in the first 48 hours of their admission. And we usually start the empirical antibiotics, but unfortunately, there is no guidance and guidelines from WHO to stop antibiotics. Once it is started, we say, okay, complete the course for 7 days. So in the second trial, what we are doing that those who are having the moderate mortality risk sign, the in between which having on an average 4% of the mortality, we are admitting all these infants in the hospital, starting the empirical antibiotic ampicillin and gentamicin for 2 days. And after 2 days, we actually reassess them. And if there is no sign of PSPI, we are doing the C-reactive protein. And if this CRP test is negative, we randomize them into two. One arm will remain in the hospital as per the routine or the standard management of PSPI. They are getting the ampicillin and gentamicin for 7 days. But the other arm, we are discharging on oral amoxicillin for another 5 days. The total sample size is 5,250, and we have completed about 4,900 cases. This study is also going to be completed by June 2024, and it will also help us to review the current guidance and guidelines. With
Yes,
yes, I'm just
sorry, I'm
two
going to
slides
ask you
more.
just to wrap up. Sorry, thank you.
Yeah. These are two slides. These are the publications from neonatal collection. These are our teams. Thanks to Ministries of Health, they participated in these research project, and also to the global partners for this. And lastly, I should present only one slide which tell us the whole story from 2009, where we identified the problem that the treatment coverage is very low and how we can improve this. And from 2009 till 2024, this is the whole story in one slide, showing us that starting from the problem, doing the research, converting research into policy, then policy into practice through the policy dialogue, then monitoring of those projects, then initiated new projects, and looking forward to see how we can further increase the coverage of PSPI. With that, thank you very much. I know I took a longer time, but I'm really sorry. I tried to finish it within 20, 25 minutes, but it's difficult for this to complete it. So thank you very much, all of you. If you have any questions, please go ahead.
That's great.
Thank you.